know that we do not know much about COVID-19. We're still learning about it. So I think it's very good. It's a very good time for us to talk a little bit about lung diseases and how COVID is affecting it. So in my talk, the outline will be mostly on looking at teleconsultation, where I think everyone is going into teleconsultation now. We're going to look at how we're going to diagnose respiratory diagnosis using teleconsultation. And we're going to look at two of the major chronic lung that we're going to be seeing in your primary care practice, which is about asthma and COPD. And of course, now we're in the recovery phase. Once in a while, we're going to get patients who were tested positive for COVID and that have recovered and now come to you with some complaints of respiratory problems. So just a very quick look at how respiratory diseases are compared to other diseases in terms of COVID. So this is the data from the United States. From their data, as you can see, chronic lung disease, whether you are hospitalized or going to ICU, it makes out on average about 9.2%. And you can see that a small proportion of as well with patients who are either current smoker or former smoker. And further on, we'll look at that. If you're older and you have more comorbids, you're more likely to have a fatal outcome. And this is all shown here in the graph here. And most recently, we've had a prospective observational cohort study from the UK, which looked at about 20,000 patients who tested positive for COVID. The most common major comorbids were obviously cardiac disease. This is consistent in all the studies that were shown, and followed by diabetes. And you can see here COPD and asthma makes up about 17 to 20%. So once we put that into a graph from where the paper came out in BMJ, you can see that chronic pulmonary disease, the hazard ratio is about 1.17. So that's about 17% chance of dying if you have a COVID-19, severe COVID-19 infection. Right. So we know now that COVID-19, if you have chronic lung disease, you're more likely to get a severe disease. So how are we going to diagnose somebody as having dyspnea? How are we going to assess them? And especially with now that we're moving into teleconsultation. So patients are going to call you up in clinic and they're going to say, "Doctor, I'm feeling breathless." So from the Center of Evidence-Based Medicine in Oxford, I think some of you will have read about the ROF score. The ROF score was introduced by a cardiologist to look for hypoxia in cardiac patients. And some patients and some studies have used it to look at how we can assess them in patients with respiratory diseases. So from the Center of Evidence-Based Medicine, unfortunately, they say that it should not be used in remote assessment of breathlessness in the context of COVID-19, and for very good reasons. The first one is that it may be normal when the patient is severely hypoxic, and they've shown that you will miss 1 in 5 of patients who are severely hypoxic. It may be abnormal even when the patient is not hypoxic. And of course, obviously, when you rely too much on objective measurement, sometimes you can overshadow your more holistic assessment of the patient. So how should we assess dyspnea, by telephone or by video? Now, unfortunately, at the moment, there's no validated test that we can tell us in acute primary care setting, how are you going to assess dyspnea when you assess them through a telephone or video. However, if you go into this website, the CEBM, they listed 7 key questions which the experts have recommended. But I'm just going to point out one, which is this one. This is the article which was published in the BMJ, which looks at the visual summary of how you will assess breathlessness through remote counseling. And we're just going to go down into here, this part here, which is examination. Assessment of physical and mental function as best as you can. So over the phone, you can ask the carer or the patient to describe their state of breathing. If you have a video, look or ask them to describe their color of face or lips. Look at the general demeanor. And few questions you can ask them. How is your breathing? So you can assess whether can they complete their sentences in one breath. Is it worse today than yesterday? To give you an idea, is it progressing? And then, what does your breathlessness prevent you from doing? So So we're looking at people, we're going to ask them, can they still look after themselves? Can they bath? Can they cook? Can they dress themselves? If they cannot, that's a very good indicator that this is very severe and we should tell them to come to a hospital. Right? Other things like if, for example, they have a digital thermometer at home, they can check the temperature and tell you what it is. A lot of people now, I think with the COVID, they keep a pulse oximeter, so they can show you what the oxygen saturation is. And then some people may have a digital blood pressure machine as well, and they can show that to you. So very quick summary, how you assess a dyspnea. So basically you check the respiratory function, you ask them how is your breathing, is it worse today than yesterday, and what does your breathlessness prevent you from doing. And of course, even in NICE 2020 and the COVID-19 rapid guideline, you want to assess whether they have a chest infection, when pulse oximeter is available, if their saturation is below 92 or below 88 in someone who's got chronic lung diseases, then this identify patients who are seriously ill. Now, obviously, patients who are mild and moderate is very gray. There's no validated test, there's no validated methods to how we can assess them properly. But what we do know is if they're severe, we have other things that we can use now. Now we've come to the part where how we're going to diagnose respiratory diagnosis in the era of teleconsultation. Now this is taken from the PCRS, which is the Primary Care Respiratory Society, which looks at a few things on respiratory care in the primary care setting. Now the first thing about asthma diagnosis, even with teleconsultation, is the probability using a structured assessment of the patient. And sometimes when they cannot come to you in the clinic, obviously now, and you can't do a spirometer, it is possible to do a trial of treatment with peak flow monitoring. And this can be done in the home environment. Now, I think everyone knows this, isn't it? This high probability of asthma. This is also highlighted in the ATS, in the GINA guideline. So patients who comes to you with recurrent symptoms of episodics, wheezing, personal or family history of asthma, anyone who's had any variable airflow obstruction, which was demonstrated during testing, and you can't find any other features to suggest an alternate diagnosis. So these are patients who are high probability asthma. You can appropriately manage them with a trial of treatment with peak flow monitoring at home. So how are you going to tell them that they have asthma based on the peak flow? So basically, it's clear and repeated evidence of a 20% variability of peak flow collected using a peak flow diary. Now, in the tertiary center, like Gleneagles, we have spirometry. I think some of your clinics do have spirometry as well. But the fractional exhaled nitrous oxide is another one which we can use, and which is helpful in when you want to diagnose somebody with intermediate probability of asthma. So at the moment, with the recovery MCO going on, we have restarted our pheno and spirometry services, of course, with the full PPE. Now, just a few things to mention about pheno, in case some of you do have pheno in your clinics, that it is increased levels and lower levels in certain situations. So patients who are men and tall, those who like to eat a lot of their greens like spinach and broccoli, those with allergic rhinitis, allergic airway inflammations, those with rhinovirus infection, children, if you do see children, okay. But there's a few things which is quite good is reduced levels in cigarette smokers and somebody who's on steroids treatment. So just have to keep in mind when you do pheno testing on them. In COPD is not that easy. Now, a lot of it relies heavily on history and basically your smoking history. But unfortunately, to formally diagnose COPD, you have to show a fixed airflow obstruction, and that is through spirometry. However, you can suspect somebody as having COPD without a spirometry and using a peak flow monitoring. And these are things like your peak flow, which is 75% less than predicted, suggests that there is some element of airflow obstruction. When you try to assess a COPD, a serial measurements of peak flow over 2 weeks that does not vary, but also remains low despite use of salbutamol for symptom relief, will suggest a fixed airflow obstruction and is suspicious in the context of supporting clinical history. Those who you find do not have variation in fluid flow, they should have. You can try them on empirical trial of dual bronchodilator therapy and see whether that improves the symptoms. In patients who do not have any undifferentiated respiratory symptoms, predictive symptoms, where the diagnosis is not clear, then unfortunately, when you have patients who you don't think whether they may or may not intermediate low asthma, then you have to go back to basics basically. You have to do a structured, logical, and context-based approach that do not rely on testing procedures. It may not be easy. Frankly, even I'm also learning on how to do it, even with teleconsultation, so I know the feeling. And just a very quick look at how you're going to tell if somebody have a chest infection. Now, patients are going to call you and they're going to say, I have fever, I have cough. Do I need to get worried? Do I need antibiotics? So there are a few things that you can look out for. They're going to tell you whether they have a chest infection or they're having an exacerbation of their asthma. So things like if you have a chesty wet cough with yellow or green phlegm that's thick and maybe smelly, you've got chest pain or discomfort, very high temperature, aching muscles and tiredness, you can suspect that they actually have a chest infection instead of asthma. Things like COPD as well. How are they going to differentiate pneumonia from COPD? So green cough, bloody mucus, fevers, sweating, shaking chills, sharp stabbing pain, nausea, vomiting, and confusion. Now, obviously, these are all guides. They're not meant to replace your clinical judgment, but they do help in making an overall judgment for your patient. Now, we're going to go into asthma now. So patients who you've seen them, they've teleconsulted you, you've tried empirical treatment, you've tried these trials of peak flows, and you've confirmed that they have asthma. So now you're going to have to tell them, they're going to come up, follow up with you. You're going to tell them how they're going to be worried. They say, should I be worried? What should I do now? So basically, you need to tell them that if you control your asthma well, you're not associated with increased risk of severe COVID. And it's actually that if you're not well controlled, you're more likely to get severe COVID infection. And I think there's a lot of talk about inhaled steroids, and we all know now steroids do work. They do help prevent severe COVID infection. We do know now also as well, smoking increases the risk of severe COVID, and is always associated with increased ACE2 inhibitions, expressions in the airways. And the COVID-19 basically affects everyone with lung diseases, and anyone's going to get worried. You're going to hear as well some patients who may call you up, they're on antiviral treatments or immunosuppression drugs. So we're not really sure on that. We need more RCTs to figure out what's going on here. So the bottom line is, if you have an asthma, they should be on inhaled steroids, except for those who uses less than 3 doses of short-acting bronchodilator per week on average over the year. If they were already on preventive ICS, they should continue it. They shouldn't stop it. Nebulizers is a very big topic right now. There's no fully randomized trials to look at this, but whatever we do have, we have it from the SARS, which is the cousin of SARS-CoV-2 now. But the current understanding now is that nebulizer is a very low risk, as it is the device or the cylinder which is driving the aerolization, the nebul liquid, and not the patient's airflow. So the risk of actually airborne or droplet infectivity is very low with nebulizers. So general guidance to tell your patients once you've diagnosed them with asthma is that they should continue their prescribed medications, do not stop their inhaled ICS, and during their asthma attack, they should refer to the red section of the asthma action plan. I think everyone is well aware of your asthma discharge plan, isn't it? Your green, yellow, and red sections. So we won't go too much into that one. And just a little bit to show you, there is some good out of the COVID for asthma patient. This is from The Guardian, which shows that I think you've seen pictures of animals coming out, able to see Gunung Kinabalu and Kilimanjaro after all this. So they're saying that the asthma is getting better because you got cleaner air. But just to let you know, I mean, when you do see patients who were diagnosed with asthma and you start them with treatment, just to show you the symptoms, how fast do they improve. So you're looking here at the percentage of the improvement and the time period it takes for the symptoms of asthma to improve. So as you can see, the first thing that's going to improve is the night symptoms, later on followed by the FEV1. And you see the timeline here is about 1 month onwards. So it's not that fast. So you have to reassure your patient who are newly diagnosed with asthma, who may be calling you up and saying, I've started my ICS inhaler, I'm not feeling better, it's been 1 week, I'm still feeling short of breath, I'm still having cough at night. So these are a few guides, a little bit of a guide to tell you how you're going to expect the symptoms to get better, right? For COPD now, well, surprisingly, there does not seem to appear an increased risk for COPD patients to acquire COVID-19 infection compared to the general population. Maintenance and your exacerbation management of COPD remains the same as it was before and after COVID. Patients who are diagnosed with COVID infection should continue their inhaled maintenance therapies. Now, just a very quick one I just put here. This is from the Canadian Journal of Respiratory Care. And basically now we are dealing with more or less into using inhalers rather than nebulizers. So just a reminder how it changes. So 1 nabule of 2.5 milligrams salbutamol is equivalent to 4 puffs of your inhaler salbutamol. Your ipratropium 1 nabule of 500 microgram is equivalent to 4 to 8 puffs. So that's a very rough idea how you switch your patient from nebulizers to inhalers. Now testing, respiratory procedures. Testing respiratory procedures during COVID. This is from the ARTPs. So basically, spirometry, gas transfer, lung volumes, and FeNO, blood gas, CPAP, and other urgent procedures should be done in exceptional cases. And this is basically during the time of recovery, which is where we are right now. During the epidemic, the pandemic, we're not going to do all this. Routine lung function infection control should be adhered to. So basically wiping down all your contact parts and everything with all the wipes. But what are the urgent people that require lung function testing? And basically, these are your inpatient cancer patients, pre-operative patients who requires urgent surgery, where lung function or CPAP is essential, right? Now, we're coming close to the end of it now. So we're going to look at now, we've looked at patients on how we're going to do our teleconsult, how we're going to assess their breathlessness, and how we're going to assess the respiratory diagnosis using a teleconsult based on the available evidence that we have. And once we've made a diagnosis, we've talked a little bit about how we're going to manage them, what your management, the preventive treatments and everything, your risks of doing, and how we're going to convert some of the nebulizers to inhalers. Now, obviously, they are also going to be patients who have already been diagnosed with COPD or terminal end lung stage disease. They're just going to come to you complaining that they are breathless. Now, obviously, these people are at higher risk of developing severe infection. And if they do develop severe COVID infection, mortality is very, very high. So I'm just going to show you a little bit about end of life. How are you going to manage breathlessness in this group of patients? So a few things that you can tell them to try and relieve the breathlessness is like sitting leaning forward at a table, or side lying with leg on the floor bent at knee. And these are some of the things that you can tell them how they relieve the breathlessness without having to come out, going to the clinics or to the hospital and exposing them, right? Other things like when you stand leaning forward against a chair, or you lean forward while you're sitting on a chair, right? But now we're looking at COVID recovery. So we're going to have patients. I've had one patient who was tested positive, recovered, and came to me complaining he was breathless. So it'd be a very good idea if you do have a little bit of an idea what it entails when you do see a patient. So the time cost for recovery for patients who were hospitalized for COVID-19. So you're looking at 1 week for the fever to resolve, 4 weeks for the chest pain and sputum production to substantially reduce. 6 weeks for their cough and breathlessness. So this is a very good thing to keep in mind, because this patient came and saw me within the 6 weeks period. He was still coughing, he was still breathlessness, right? So it's always good to know this, and you given good clinical assessment, and you can decide whether something you need to worry or not. And look at that. You need 3 months before most of your symptoms have fully resolved. And even then, you will still have fatigue, which will still be present. And 6 months for you to fully recover from a COVID infection, right? You are going to see them in your clinics. Sooner or later, they're going to come with symptoms, patients who have been treated or diagnosed with COVID before, right? And I think that's it. Just a very short talk about chronic lung diseases and COVID-19. Thank you for listening, and stay safe, everyone.
Thank you so much, Dr. Arfian, for the updates. For now, we don't have any question yet from our viewers, but if you have any question, you can always WhatsApp me at 014-6700-985 at 014-6700-985, so that I can pass your question to Dr. Arfian later on, so Dr. Arfian can answer you and we can come back to you through WhatsApp. So before we end this session, any last advice from Dr. Arfian to the viewers out there?
I think the main thing is a lot of people will be worried. Patients with lung diseases, patients who's got coughing, especially with COVID going around, everyone they're going to be worried. Do they have COVID, or is it COVID's going to make them worse? So I think the best thing is always approach them in a structured clinical context, use whatever evidence that we have about assessing dyspnea. The main thing is that if they are on any treatment, they should continue the treatment. And always, as usual, they need to be safe, avoid all the places that they're supposed to be avoiding, all those crowded places, and only seek urgent medical care if when necessary.
Thank you once again, Dr. Arfian. We have come to the end of our online CME. Thank you everyone for watching us today, and please do check our Facebook post as we will keep on posting updates from time to time. And also, we will have another one CME session with our interventional cardiologist and physician, Dr. Chu Chong Mao, on next Friday, 3rd of July at 5:30 p.m. If you are interested, please contact us and we will send you the link to join the session. Hope everyone is well. Please take care of each other, stay positive during this pandemic, and thank you once again, and see you next time.